Hey, Sid Mitchell, welcome to the Debrief Show. Thank you for being our first guest in this live, first ever time we are coming on Fiji TV. Why don't you introduce yourself to the audience, who you are, what specialty do you follow in the Ministry of Health, and what's the task force you're leading?
Hi, thank you. I'm really excited to be on the show. So my name is Jason. I'm what you call a program person. I run a HIV program in the Ministry of Health. It's a new unit that the ministry has set up in response to the HIV situation in the country. I have a programming background, which means I put together all the various pieces to make a disease area respond effectively to a situation. So that's my background. So I started off in HIV medicine in Fiji many years back, almost 20 years ago, in the northern part of Fiji. And then I worked regionally in a HIV program, and then I worked internationally. So I was working in Myanmar. And then I've returned to Fiji recently, and then I've started to provide support to the Ministry of Health in responding to the current HIV situation. So I'm the chair of the National HIV Outbreak and Cluster Response Taskforce. It's a special task force that has been set up by the HIV board to help respond to the situation that we're currently facing in Fiji with the outbreak of HIV.
Now, HIV has been a growing concern in the public, especially in Fiji's news. And the public is aware, but the conversation, the depth of the conversation isn't fully understood. So can you tell us, from your aspect, how does the HIV epidemic right now is currently looking in Fiji?
So I think it's important for us to take a couple of steps back in terms of the numbers around HIV. So for the last 5 years, before 2024, Fiji reported about, on average, 215 cases a year. In 2022, the number started to go up. So on average, we were reporting 215 cases for the last 5 years. And then in 2024, that number increased to 1,500 cases. So that's a dramatic increase in infections of HIV. And when you're working in the HIV space, when you have an increase in numbers, the first question you ask yourself is, are we just because we are testing more, so they were finding more people? So when you put that aside, it's clear to us that this is a definite rise in infections. So it's an epidemic in the sense that it's above the normal, the numbers you would normally expect, which is 215 cases. So for 2024 alone, we reported 1,583 cases, which is a large number, a large jump of infection. So I guess that's kind of like the context in which we're sort of seeing this epidemic. So HIV has been recognized as a pandemic since the 80s. So we've never controlled the HIV epidemic globally. And what you have is these countries that have reported increasing cases. And so Fiji is now recognized as having the fastest growing epidemic of HIV in the world, which is really not a statistic you want to be famous for, but that's our reality.
And how is it compared to the rest of the Pacific nation? I think we often heard stories that PNG was once one of the leading countries, and some other Melanesian countries. So suddenly Fiji is in the radar of the whole world. How is that Fiji took sudden leap in this stats compared to other Pacific nations?
So if you put Papua New Guinea aside, Papua New Guinea has always been an outlier in this region. So there are 22 countries and territories in the Pacific. And Fiji has always been the highest in number of cases outside of Papua New Guinea. Most other countries, some countries have like 2 or 3 cases, some have 5 cases. So Fiji has always been a country that sort of sits above other Pacific Island countries. But we have to be mindful that we have a larger population here, so that sort of accounts for it. But I think what has changed in terms of this region is that we've got new risk factors in Fiji, and a program that doesn't currently respond to the new risk factors in our population. So that's why you see this large increase in HIV infections. But I think it's important for us to also be mindful that Papua New Guinea is also experiencing a crisis of HIV. They're seeing higher numbers of infections than they've ever had before. But this is the first time that Fiji actually sort of is ahead of Papua New Guinea in terms of HIV infections. And I think it's really to do with the new risk factors that we have in our population. that drive HIV.
Infection like HIV is not it's just one of the many diseases and virus cases we have in the country or even in the health system, given we're just coming out of COVID, and then we have yearly pandemics of different leptos and TB and the forever battle with NCDs. What's from your, and these kind of things could be a huge challenge to a system, but what's accelerating this shift from your expertise in this field?
What's making HIV a bigger problem that we would normally have is that, like I was saying, the new risk factors. So as you all know from the media, there's been an increase in number of reported cases of people who use drugs. Drugs in itself does not put you at risk of HIV. It is the practices that are associated with drug use, particularly intravenous drug use. Intravenous drug use on its own does not cause HIV. What causes HIV when it comes to intravenous drug use is the sharing of unsterile needles, which means these are needles that have been shared amongst people. The other practices that's very common here in Fiji is this practice, there's an umbrella term which we refer to as blood sharing practices. And the famous one you would have seen in the media is the Bluetoothing, and that's just one of the many practices. There are many blood sharing practices here in Fiji. When you have a situation where you're sharing needles and sharing blood, the risk of HIV transmission is really high. In addition to HIV, we have hepatitis C, which is very infectious, much more infectious than HIV, and that is also spreading amongst our intravenous drug users. And what makes it very difficult for us to manage the situation is we don't have an effective harm reduction program. That means that anyone that is using intravenous drugs and is sharing needles and is sharing blood is most likely to be at risk of HIV. And this is what's leading to the increase in number of HIV infections. In addition to that, we have long-standing risky behavior, such as like not using condoms consistently. And our population has not been a population that uses condoms. Despite the free availability of condoms, we don't have that practice of consistent condom use. So if you have someone who is infected because of drug use and they're still engaging with their sexual partners and they're not using condoms, they're transmitting. So we've had multiple ways in which HIV is transmitted in our population. So amongst drug users, sexually between partners, sexual partners, and now it's infecting our children as well through babies, through mothers who are infected with HIV. And there's no treatment available to these women, which leads to infection.
It's interesting because when you look at global spread of HIV, especially in modern developed countries, IV drug isn't one of the main causes of spread. It's usually through sexual activities. Yeah. So in Fiji, how is that? We often don't see the mentioning and conversation around sexual health and all best practices. So why is sexual activities and other efforts are not being talked about when it comes to spreading of HIV?
I wouldn't say that it's not talked about. I think you see a lot of messaging around this, right? You know, for over 20 years now, the talk about having safer sex or safe sex, use condoms, have one sexual partner, you know, all that sort of messaging is out there. But that message is not sufficient enough to result in behavior change. And what happens in programs like a sexual health program is you need to have skills building and behavior change interventions paired with the messaging around, you know, the need for using condoms and all that. So I think the messages are out there. It's not affecting appropriate behavior change. And as a result of that, people still engage in high-risk behavior. But the other thing that we rarely ever talk about is the vulnerabilities in our population. Vulnerabilities are basically situations that people are in that cause them to be at a greater risk of HIV or greater risk of sexually transmitted infections or teenage pregnancies, for example. And these are typically vulnerabilities such as gender-based violence or the socio-cultural issues that are dominant in our communities. That means people are at a greater risk of HIV or STI infections. And as a result of that, you know, even though they understand that they should be using condoms or they understand that there are certain behaviors they need to practice, it's not resulting in their ability to actually put that knowledge into actual practice. An example of this, like if a woman is in a relationship in which there is violence, and she's fearful of having a conversation with her partner that she knows is having multiple sexual partners in addition to her, it'll be very unlikely for her to be able to negotiate safer sex. So theoretically, knowledge, her knowledge might be strong in terms of I know I can reduce my risk of HIV and STIs if I ask my partner to use a condom. But if I ask him to use a condom, he's most likely going to hit me. And so therefore, I don't ask him to use a condom. And therefore, I'm at risk of HIV. And that's just one example. But there are multiple examples of where people's vulnerability puts them at greater risk of STIs and HIV.
If you were given the chance to conversate on one of the stigmas and narratives that's out there in the community right now, what is one thing you would identify that you have seen it over and over in a repeated cycle, and how do you address that issue to the community right now? What is one thing you basically have heard that's a complete misinformation, and yet till today, despite all the advocacy, it's still being spread?
I think the common one, and it's a common issue around the world, that only certain people get HIV. Certain behavior results in HIV. What we are seeing is that that's not the case. So even though you might be a perfect person, because of the risk of somebody else that you might be associated with, like for example, if I was married and my partner was engaged in high-risk behavior, yet I live a very pristine, perfect life, what is happening with my partner actually impacts me. Because of their decisions, it impacts me. And I think the myth that only certain people are impacted by HIV we have to do away with that, because everyone is at risk of HIV. And that's something that we are showing in Fiji, is that it's right across the board, everyone's at risk of HIV. And it's everyone's responsibility to become aware and for them to identify their own risks and the risks of their sexual partners, or if they're drug users, the risk, the risks and the HIV potential of the people that they're engaging with. And this is something that's important. So knowledge is really powerful. And I think this is a good example of
seeing how our current law system is and the enforcement of it. By criminalizing these drug users and drug users in general, mostly, who might be carrying additional such as HIV, is this the right way for prevention?
No, and there's never been a country which has appropriate evidence to say that criminalizing a drug user is going to solve the drug problems. I can only speak from a health perspective. Criminalization of drug users results in risky behavior, because what happens is it drives people underground and therefore never exposed to any beneficial programs that might be available. So even if Fiji had a strong needle and syringe programs, so long as you're criminalizing people who use drugs, which means they have to hide their drug use and therefore not approach a harm reduction service or a program that is to reduce their risk of HIV, they'll never benefit from the program. So in most countries that are successful with programs around drug use, they will often have an intervention which reduces the criminalization around drug use. From the health side, we're not saying that drug use should be allowed to happen. That's not what we're saying, but what we're saying is we need to use interventions to reduce people's risks to their health. And that's what our public health program is all about, just reducing harms around infections.
From your field of work, what are some hidden and silent data patterns have you seen in terms of where these HIV cases are coming from? Are we seeing, I know often it is treated, most of this infection and risky behaviors are things in the city life. It's not done in the Vanua, it's not done in the villages. But how does this data separate in terms of, is it like a central division where you're seeing, or urban areas? And what's the story in the maritime and rural spots?
The one thing that we've noticed from the data, and the numbers speak for themselves, and this is the beauty of numbers, they don't lie. And what we're seeing from the data is that for the first time in our history, HIV infections are coming right across the country. So there is no place that does not have HIV. And if we haven't reported a case there, it's most likely because we haven't tested them. And so we don't know what the HIV status is right across the country. But we are seeing infections right across the country. There's no such thing as any hidden information behind the data. Whatever data we have is publicly available usually. We talk about the concerns we have when we talk publicly about this, because we need people to be aware of what the risks are, and we need people to be aware of the data so that people know what their risks are and where the concerns should be in our community. So what we're showing for the first time is that every population group now is at risk of HIV. In most countries in the Asia and the Pacific region, it's only key affected populations or certain groups, such as men who have sex with men, sex workers, drug users, that are most at risk of HIV. In Fiji, it is right across the population, which including babies, because of the risk that women are at now because of HIV. So it's like all population groups and right across the country. And I think with the way that our populations move around so much, it is very difficult for us to say there's no infection anywhere in the country. Much like COVID, where you have people, because it's an infectious disease, if people are moving from one place to another, they're most likely taking their infection with them. It's the same with HIV. So, we can expect infections to be in every part of the country.
Have you seen this kind of pattern in any other countries you have visited or done research on, like where it is literally across all field and not particular groups?
Yeah. This type of epidemic, which we're currently experiencing here in Fiji, is where you would see this type of epidemic in sub-Saharan Africa. The stuff that would be in the news that we would all be aware of, that certain parts of Africa have large groups of people who are infected. Every population group is infected with HIV. That's the direction we're heading in Fiji. I don't think we're quite there right now, but we're heading there. And it'll only a matter of time before the data actually tells us this is actually happening.
The conversation of HIV always follows with stigma, right? The suppression of the news, or the fact that you are a person living with HIV, or you want to seek treatment, and this definitely plays a huge role along beliefs, customs, religious practices. How do you tackle stigma around this field?
I think we always start with information. Knowledge is very important. But I think a lot of times there's a lot of misinformation out there in the community, a lot of myths. In the early days of HIV, there was this concern that you could transmit it by touching surfaces and HIV would be transmitted. This is not the case. Once you provide information to people, they can understand that their myths are actually, so myth busting essentially. So what we try to do is we try to identify, and every community has different myths, and we try to identify what those myths are and educate people about those. And I think showing people that through evidence and through data that this is not actually correct is the best way to go about this. So, stigma is something we face right across our society. And I think for us, it's knowledge that's made the difference over the years. And I think it's having these open, frank conversations, such as platforms like this, where people are just having a Talanoa session about some of the realities, breaking these myths down and breaking things down into conversations that people actually understand. And I think that's the way that we can address some of the stigma and discrimination.
The thing is that I feel like people doesn't actually understand the age demographic too, because from during our research on this topic is that people think a certain age group also gets HIV, meaning once you're adult, 18 plus or 20 plus, or you're a working class people. But we have seen young kids, even high school students are getting HIV. What's the role of communities to play when it comes to addressing that? Like our recent case where a little child got hit by a car, and then people rushed there was social media videos where they rushed to pick him up and quickly carry him to take him to the hospital. But that contact of blood, which we make it very natural as human, but then this could be a sign of infection in the future. How do we even navigate through those kind of channels when all age demographics becomes a certain risk?
There are certain principles that we all follow with regards to blood and body fluids, and we know this, like sexually, there's certain practices that we engage with sexually that put you at risk of HIV. Also being exposed to blood, like in the case that you've used, the example you used here where someone's hit on the side of the road, they're obviously covered in blood, and people are potentially at risk. But the risk is based on both sides of the situation. So if the person is HIV infected, and if their viral load is high, meaning they're not on treatment, and their viral load is high, and you who don't have HIV is exposed to that blood, you can only become infected with the blood if there is direct contact with that person's blood and yours. So if your skin is intact, there's no potential for infection. But there's what we call these universal precautions that we always talk about, so wearing gloves, putting a barrier between yourself and the other person's blood is a practice you could do. But oftentimes it's like a human response to reach out and to help somebody. And In those situations, you have access to what we call post-exposure prophylaxis, which is basically medication we give to somebody who's been exposed to HIV in some shape or form, or the potential of becoming exposed to HIV. You give them this treatment and it reduces their risk of becoming infected with HIV. So those options are available here in Fiji. And people just need to be aware of that. So post-exposure prophylaxis can be used with healthcare workers who are exposed to body fluids that are HIV, might be HIV infected. It also accessible to somebody who might be sexually abused or raped. They have access to post-exposure prophylaxis as well. So there are lots of interventions that can be used to reduce someone's risk of HIV.
What role do you think our education system has to play a role? Because going back in the days of my primary school and high school, our conversation of HIV or any drugs or any other disease matter, even most common one in Fiji, diabetes, it's like it's healthy drinks or don't have abstinence to prevent any of STI infections. This education system has been there for ages. In today's age, how would you revamp that to address this kind of upcoming challenges we're having in the community?
One of the recommendations globally is for the introduction of comprehensive sexuality education. And I know there are programs here in our school system that is age appropriate, and they've introduced it many years back. I think it's for family life education. I don't think it's appropriately reflective of the current risk factors that we have here in Fiji, and there needs to be some open opportunities for us to review the current programs that have been delivered by our school system and have it more updated to what is actually appropriate for what is happening here in Fiji. The reality, and unfortunately the health, is often at the edge of this reality. You see the outcomes of risky behavior, they end up in our health service as a result of infection or unplanned pregnancies and things like that. So I think there needs to be some realities about realities addressed in some of our programs that have been delivered by the school system. Comprehensive sexuality education, if done well, is quite comprehensive, and it addresses even risky behaviors such as drug use as well. And I think it's time that our programs in schools talk about the harm reduction interventions that should be available to our communities, and younger people as well in school are at risk of various infections such as HIV and other bloodborne viruses. But I think there's a need for us to really look at these programs and make it more realistic to what our students and our young people are becoming exposed to. You're right that younger people are becoming infected with HIV. In the last 3 years, we've had a 45-fold increase in adolescents who are becoming infected with HIV. That's a huge jump. And it just speaks to the risk that our young people are exposing themselves to. And a lot of it has to do with the absence of knowledge and behavior or skills to reduce their risk of HIV infection or other bloodborne viruses or unplanned pregnancies. Like, we know that the rates of teenage pregnancy is actually going up. In the context of programs that are in school and out of school, something's not right here. And I think this is an opportunity for us to relook at what we're doing and seeing how we can do it better. There's no perfect program. Even in countries that have comprehensive sexuality education, students still get infected with HIV, they still get pregnant, but the rates are so much lower in those countries than ours. And I think this is where we need to be asking ourselves some honest questions about what we can do better, so that we can reduce these rates of infection and unplanned pregnancies.
Now, to get the message to the young audience, like, you need a good, supportive, and comprehensive media outreach, and especially figures which students and kids can relate themselves to. Mm-hmm. How do you think a role of media plays in HIV prevention in Fiji, or at least in terms of even advocacy around the whole situation, where they just don't create awareness, but they also give possible solutions in how they can protect themselves?
Yeah. I think, and I was saying this earlier, I think there's a need for us to come up with a different approach, to have open, frank discussions about what is happening. And I use the term talanoa. And I think it's about getting the right people with the right knowledge at the appropriate level of your various audience that you're targeting, to have these frank conversations about the skills and the behavior that we need to be practicing to reduce our risk of HIV and other bloodborne viruses. because I don't think it's enough to give awareness anymore. It never has been. There's been no evidence that just giving awareness and information is enough to result in people's behavior change. And there's a lot of reasons why that is. And there's a lot of reasons why it's not as simple as just giving information, or just because you know it doesn't mean you result in a change in behavior. So I think there's lots of complex reasons why behavior is difficult to change. And a lot of that oftentimes requires individual one-on-one sessions with people to reduce people's risk of becoming infected with an infection, or reducing their risk of unplanned pregnancies, for example. So I don't think any media has that ability to really address individual issues, but it certainly is a good platform to have some open, frank discussions, sharing of good, strong, evidence-based information to talk about how we can actually reduce individual risk. I think the media it's a good platform in which we can do that. I think the media needs to be savvy in terms of identifying who their target audience is, what their risks are, and then talk about the risks on the show, rather than making some general statements about what might not apply to the audience that are actually watching or listening to their program.
With the majority of these cases being mostly the younger population, one of the articles that came out on the news was that 70% of new cases are usually below the age of 40, So, and often we'll see our leaders and other religious figures will say culture plays a huge role, and it is mostly influenced by Western culture. So our acts of what we see on TV, on our phones, is what we are practicing in our communities. And do you think that culture really plays a huge force in this figure? Like, has Western influence really is the fuel to our HIV pandemic in Fiji?
It's one of those, I suppose, complex questions, because I think on the one hand, we've opened ourselves up to culture that comes from outside of Fiji and outside the Pacific. But on the other hand, our own culture hasn't caught up to help our communities deal with the culture that has been adopted by all of us. We have adopted this culture. Our culture in the country has not caught up with the new challenges that our communities are now facing. For example, we still say things like, talking about sex is taboo. It's taboo among certain relationship groups within our family, like fathers and daughters, or that sort of thing. And I think one of the things that we need to be aware of is that our communities are being challenged by behavior that we are adopted from outside the country, but our practices in the country are not catching up with what needs to be, the way that we need to be responding to the situation is not quite there. And I think there's an opportunity for our cultures to have some open, frank discussions, for us to be mindful that the communities and the culture in which our communities are practicing is also changing. And therefore, the way that we approach it as a community also needs to change. And I think this is the part that is often slow. And it's not unique to Fiji, it's happened everywhere else in the world. And even in the most Western, most developed countries, it's still difficult for people to have some frank discussions around sex, for example, because it's just culture or religion that leads us to stop having these open, frank discussions. And I think this is where we have to catch up.
One of the recent reports from ministry came is that majority, when you look at the age, the race demographic, of course, if you look at the gender demographic, majority are males, and then also if you look at the race demographic, majority are Itoke males. Why is that such a large proportion? They make up almost 70% of the proportion, while the rest of the races make such little. Is there something happening in terms of in the community of these races? Could be a conversation of shame, where they are not openly about their health status. They don't want to conversate on it. They don't want to seek guidance. Hence, they are fueling up the numbers so big. And if that is, what would be a way around it to especially target a huge demographic of the community?
The simple answer to that is we don't know. We haven't done enough studies. The data does not actually tell us why this is the case. what we have seen since 2021-22, there's been a disproportionate increase in males becoming infected with HIV, and the majority of those males are engaged in intravenous drug use, risky intravenous drug use. So we know that's a driving factor, but why the majority of those who are engaged in risky behavior are our indigenous population to Fiji, we don't know. There hasn't been sufficient studies for us to know why this is the case. Everyone in this country is exposed to the same information. They're all exposed to the same programming around HIV and STIs. But why certain groups have more infections than others ultimately is as a result of risky behavior and vulnerabilities that put them at greater risk of infections. What we do know from the programming is a lot of our programming is focused on certain ethnic groups in this country, but yet despite that, these groups still have higher risk of infections than other community groups. I think there is some things you can put down to numbers, and that a lot of it is because this population group is the largest population group in the country, over 60% of our population, the Italke population. So that might account for some of the infections, but that's not always the case. A lot of it is as a result, as I said, because of risk factors. But as to why there are differences between the various ethnic groups, we don't know. We think a lot of it has to do with health-seeking behavior. And what we do know is that for those, a lot of our programs are mostly target Italke population groups. And as a result of that, they're more exposed to the benefits of testing because a lot of the programming is targeted towards these particular groups. And that's the way health programming is. If there are more infections in this group, you focus a lot of your efforts on that group. What we have to strike is a balance, making sure that we don't miss out any other population group here. And in Fiji, we need to do better at reaching out to other ethnic groups. But what we do know is anybody that needs treatment in this country always ends up in the Ministry of Health. So it's not the case, because a lot of people say, okay, maybe the other ethnic groups are getting treatment in the private sector. All treatment is only available through the Ministry of Health. So no matter what happens, they all end up, our data still comes from the Ministry of Health, and it's always reflective of who's engaged in the treatment and care program. And right now, it's the majority Italke population.
Now, the topic of religion is always sensitive around these kind of topics, isn't it? Because of the tabooness, not just amongst communities and cultures, but in fact, religious leaders. Being a Muslim person myself, I've never seen conversation of any type of sexual health or any type of conversation being done at a mosque. And I think others can relate the same at a temple and a church. What roles and mindsets should religious leaders should change towards people living with HIV, and how we can help them, and how do we create awareness amongst members within the whole population?
I mean, if you've lived in the Pacific, you know that the faith-based organizations are central to our way of life here. Like, you can't do anything without involving the church or other faiths. And that's our success in HIV programming in Fiji has been because we've involved the church. We've involved faith-based organizations. However, over the years, the involvement of faith-based organizations has dropped off, and we need to re-engage them in our programming around HIV, because the church has a very large audience. They have a very influential voice in our community. Some churches do open up about the risks that their congregation might be exposed to, such as high-risk sexual behavior or practices such as intravenous drug use, while other groups may not be so good at talking about it so frankly or introducing interventions for their congregation to be exposed to. So I think it's about engaging more and more faith-based organizations in the works that we do, creating links between the communities that are impacted by HIV and other bloodborne viruses with faith-based organizations. And I think that's the role that the Ministry of Health has in brokering between the two groups, like the people at risk of HIV and those who are from faith-based organizations. We've been successful at this in the past, so it's not the case that we've had no track record of it. We've had very good success about engaging faith-based organizations in our response. So it's just about getting back to some of the good practices. The church and other faith-based organizations have a very important role. They are central to all parts of our life. So their role in talking about these risks put our population at greater risk of HIV and other bloodborne viruses is so important. And I think this is an opportunity for us to relook at what we're doing, and making sure that we engage with faith organizations to get us ahead of what we need to do.
Innovation has always been trend for Ministry of Health to tackle traditional practices. Let's look at our traditional practice of medicine, the herbal medicine, which has been a huge battlefront for Ministry of Health, especially when it comes to fighting for diabetes. The needle exchange program and the PrEP medication is a global standard, and is something Fiji is definitely bringing in to tackle it. Can you explain the audience what is the needle exchange program, what it's supposed to do, what it does, and who has tried it, and what could be some of the benefits we can get in this country?
So I'll start off with needle and syringe programs. Needle and syringe programs are what we call harm reduction interventions. And these are interventions we put in place to reduce people's risk of infections. So when we talk about infections, it's not just HIV, it's other bloodborne viruses. And I shared with you, hepatitis C is another infection that is becoming quite common here in Fiji, and it's a result of blood sharing and the sharing of needles and syringes. The needle and syringe program basically means that we, as a public health interventions, like the supply of condoms, make needle and syringes available to intravenous drug users so that they reduce their risk of becoming infected with HIV. Because drug users cannot get access to needles and syringes, it means they're sharing needles and syringes. When things are hard to get, you end up sharing them. And like condoms, you don't want to share needles and syringes. You want to make sure that people have their own supply of needles and syringes. They use it for themselves, and then they dispose of it safely. And so a needle and syringe program basically makes needles and syringes widely available to anyone who might be wanting to engage in intravenous drug use. Intravenous drug use is quite common for a lot of people who use drugs in Fiji, and it's because the drugs are widely available. So you want to make sure that you put into the hands of any drug users needles and syringes so that they reduce their risk of HIV and other bloodborne viruses. Needle and syringe programs are currently in use in 93 countries, and these are 93 countries that have populations of people who use drugs. Even the most conservative countries have needle and syringe programs. And some of them not so conservative countries also have needle and syringe programs, and they've been shown to be very effective at reducing HIV infections. And our nearest neighbors, Australia and New Zealand, virtually have no people who use drugs who become infected with HIV. And in Fiji, on the other hand, almost the majority of people who are becoming infected, especially males, are as a result of intravenous drug use. And it's because they don't have access to sterile needles and syringes. And so a needle and syringe program, when introduced into Fiji, will mean that we will reduce the risk of transmissions as a result of the sharing of needle and syringes. For PrEP, or what we call pre-exposure prophylaxis, is basically we're giving people a tablet that they take either daily or as required to reduce their risk of becoming infected with HIV. So when you're taking the tablets or injectables, there's three different forms. So there's tablets, there is injectables, and then there is a ring that women can insert inside the vagina so that it slowly releases this medication. What this medication does, it's one of the same medications we use for HIV treatment and also for hepatitis B treatment. It reduces the body's ability to allow HIV to replicate. So if you don't have HIV and you're taking PrEP or pre-exposure prophylaxis, it means that if you become infected with HIV, the chances of the virus being able to live inside you is reduced drastically to almost 100%. So it means that it's a very strong intervention that can help reduce your risk of HIV infection, particularly around sexual transmission of HIV. So these are two very powerful prevention interventions that can be easily introduced into Fiji to help us reduce the risk of transmission in our community.
UNAIDS has heavily emphasized on funding and especially promotion of needle exchange programs in Fiji. But we have leaders who are having clashbacks on this, where their suggestion or their opinion is that such programs will increase the usage of drugs, and that will create more fueling and more consumption of drugs and further deteriorating our communities. How would you counter these kind of opinions?
Well, the first one is that people are using drugs anyway, and the needle and syringe program just reduces their risk of HIV transmission and other bloodborne viruses. Most of the evidence from around the world, there's been nothing that shows that putting needles and syringes into our community results in drug use. That's not the case. This is the same argument they use with family planning and the same argument they use with condoms. If we give condoms, it's going to make people have more sex. This has not been the case. People are already engaged in sexual practices that are at high risk. People are still engaging in, whether we have condoms, we don't have condoms, they are engaging in sex. And so condoms and family planning is there to reduce people's risks. It's the same thing with needle and syringe programs and PrEP. There's no evidence anywhere in the world that this means it results in an increase in risky behavior. In fact, as a result of it, it reduces our risky behavior. And that's ultimately what a public health program is all about. It's about reducing transmission and infections in our community. And to reduce the burden on our health system, which is quite heavy right now because of so many infections that are very hard for us to manage right now.
If given you get the front seat today and you got the full freedom of funding to roll out this kind of project, the needle exchange program, what kind of intervention and project would you launch tomorrow? For example, we've seen the condoms availability everywhere, especially at all the health centers. We have FNU Clinic and all the universities have their little station booths where dispensers where you can get condoms. What kind of rollout would you do for needle exchange programs across the country, and who would be the first target?
So the plan is initially, we've done a rapid assessment, this rapid assessment that has been done by experts from Australia have identified that the most logical place for us to start off with is our 3 hub centers. The 3 hub centers are treatment centers that have been set up specifically for HIV and STIs and often reproductive health services and sexual health services. And this will be the starting point for the distribution of needle and syringes. There are 3 clinics in the country right now that are immediately able to distribute needle and syringes. After that, we're looking at the use of retail pharmacies. So these are pharmacies that are private. They're willing to help in the distribution of needle and syringes. Then after that, we'll be using peers, so communities or peer-to-peer distribution of needle and syringes. That's a very effective intervention. So these are 3 quick wins for us, for us to get needle and syringes out into the community.
Let's talk about strategies in action for the ministry. What's the current approach from the HIV task force? What have you guys tried? Is there any, even if you have failed in certain projects or ideas, but are you reinventing the wheel to get the whole program running? What is some of the things currently is in ministry's pipeline? And
so obviously is what we're calling the introduction of high impact prevention interventions. One of the things that we have not been very good at is our focus on prevention. And we're not good in the sense that there are no new risk factors in our community, but we don't have any effective programs or any programs for this particular group. And one of them is PrEP, and the other one is a needle and syringe program. So the whole idea is that we want to introduce these interventions as quickly as possible to reduce the risk of HIV in our community. The other thing that we need to get really good at is to increase the number of people we put on treatment, because currently not enough people are actually on treatment. Treatment is another form of prevention. If someone is HIV infected and they're taking their treatment and their viral load is suppressed, which means they can't transmit the virus to somebody else, it reduces our risk of transmission within the community. And we don't do that very well currently. And I think a lot of it has to do with the overwhelming number of cases that we have and the limited number of health workers that we have who provide HIV care. So one of the things that the Task Force and the Ministry of Health's SRH and HIV unit will be doing is to quickly, in any way that we can, increase the human resource that we need to be providing as much treatment and care in our community, and also to be introducing the prevention interventions. The one thing that ministries of health do not do very well is prevention programs. And so we're not going to try to do that. We're trying to partner with communities. Communities are best at doing prevention, and non-governmental organizations and community groups will be the ones who will be leading us in prevention. We will be having a lot of support from Australia to introduce these new interventions and using our communities to do the prevention for the Ministry of Health. So this is some of the interventions that are coming.
Ministry of Health often has the struggle of limitation of resources. So procurement is a huge upcoming challenges in ministry. How is ministry innovating around that, and who are some of the government governing bodies or donor agencies that are stepped in so far to help ministry tackle all these backlogs?
Yeah. So one of the things that we had to get right from the very beginning is around our data. Previously, we were ordering for a smaller number of people, and which means that we were never going to get our orders right. You need to know what to expect in terms of people who need treatment and people you need to prevent from HIV in order for us to get our orders right. We've never been good at that. So we need to get that right, first of all. So in terms of organizations that are helping us, the Australian government has been um, very forthcoming with their support. Immediately when we first called the outbreak, Australia was there to provide support. And they've made access to funding to engage the work of the UN system to help us with procurement. The Fiji government has made a decision to engage UNDP, which is a UN agency, to help procure or buy our drugs and like our test kits for HIV on behalf of the Fiji government, because they have access to cheaper, more readily available antiretrovirals. And so our limited money goes further if we're using the UN system to procure for us. Other donors have been very generous. The New Zealand government, for example, recently gave us $5.2 million. And that will also help with the procuring of additional resources that we need for this particular response. There isn't enough resources around for what we need to be doing, so we need to be careful about what we're doing. I think the challenge for us is making sure we have a good balance between what we do and what we bring into the country to help us do that work. And so I think that's where we're trying to get that balance right.
A lot of the doctors we interviewed prior to this coverage of this episode was that their biggest concern is the HIV decree. They often have raised it is often outdated because of the time it was established, and it needs to be relooked, reformed to meet today's standards or even global standards where it can be benefit to them. So, would you be able to explain what is the HIV decree? Why does it exist? What is supposed to do? And if you have any opinions on it, or like should you if we should relook at it as a reform, what would be some of the places you have in mind?
The one thing I must say, and I think to dispel a myth, is that this HIV Act is a very forward thinking, and it was of its time a globally celebrated HIV law. It's one of the few countries that have a dedicated HIV law. It was written so well that it allows us to introduce any prevention intervention, including needles and syringes, which is covered under this act, which was written in 2011, even before we had a big issue of intravenous drug use. It is a very good legislation, which needs some tweaking. There are some provisions in there that make it difficult for us to do some of our programming work. For example, there are things in there that are better suited to be in a guideline, for example. For example, they talk about things like testing. Some of those things should not be in a law, because if we need to update the guideline, you can do that very easily. Unfortunately, acts or legislation is very difficult for us to update. So there are parts of that act that need to be updated because guidance around appropriate testing approaches cannot be updated because it takes so long to update an act. So yes, there are some parts of that act that need to be updated, but it's a very good legislation, and it came about at a time when we were trying to protect human rights of all Fijians, including people who are HIV positive and communities that are affected by HIV. That law provides a lot of protections for our communities and for people living with HIV. That's why that law came about. And that's why it is a celebrated law globally, because it has such great provisions in it. But again, there are some parts of it that can be amended, and in due course, we will have an opportunity for us to amend some of those provisions in the Act.
Working in the HIV task force, you must have met a lot of infected individuals. And what are some of the messages and concerns they have raised, which you have taken in as your personal suggestion to reforming the task force or having implementation of additional programs?
One of the things that no matter what we do in our HIV program, if we make testing available, if we make treatment available, there's always a risk that we will run out of stocks. And I think we've seen in the media that there's always this stock out issue that we have here. And our communities of people who are living with HIV are always concerned about not having enough drugs for them to be all running out of drugs. And so this is something that we want to really address. The other thing that our communities like to do more of is they want to be part of our programming, which means they need to be part of the planning, the implementation, and the monitoring of our programs. And all communities want to be part of it. There's this mantra that we have in most programming now. It's that nothing about us without us. And communities have a very right reason to want to be part of everything that we do because it concerns them. So it's one of the things that we haven't done very well in recent years. It was something that we had very strong initiatives around early on in the epidemic in Fiji, but somehow over the years, the communities are less and less involved in our work. Communities should be part of every part of our programming around HIV. So in the coming months, people living with HIV and key affected populations will be part of every aspect of our programming. So people living with HIV will be working in our clinics, providing peer-to-peer counseling. People living with HIV will be part of the planning around our HIV programs. They'll also be part of a monitoring of our services, which means that anyone that is going to be benefiting from any of our clinics or any of our outreach programs will have an opportunity to monitor, to tell us how we can do it better. And so these are great interventions that we are very happy to be including some of the work of the new unit and also the task force. It's an area that really strengthens what we do, and it really gives us a real sense of what challenges communities are actually facing, so that it's reflected in the programs that we implement. And I think that's something that we really want to look at.
One of the interesting article I read about you was when you mentioned about cross-border threats of the infection we have in the country, and then that kind of got me back to thinking back couple of years back when Africa had the Ebola virus and how we have zoned out or coned off Africa as a possible threat. With Fiji's epidemic numbers is growing at such a scale, do you reckon we can become a threat to the region in terms of cross-contamination into other nations, especially given we have so many foreign students, especially from University of South Pacific, who comes to study, and can they be infected in their youth activities, and then we can be a potential threat to the rest of the region?
I think there's definitely a concern for us in Fiji as well, because we recognize that Fiji is the hub of the Pacific in terms of education, in terms of commerce, in terms of air links between the smaller island countries. Fiji is a hub in which they come to, and then they travel outwards to other countries. So it's definitely a concern that we're concerned about here at the Ministry of Health in Fiji. But also, we acknowledge the concerns of other ministries in the Pacific, because they have large numbers of students, as you pointed out, that come to Fiji to school, which means they're here for long periods of time, and are definitely exposed, because the same behavior that we have here around sex is replicated in other Pacific Island countries. Frequent multiple sexual partners, low condom use is a consistent problem we have right across the Pacific. And so if they have those behaviors and they come to Fiji, which we have lots of HIV infections, they're at risk of becoming infected with HIV. And then if they return to their home countries, they are exposing other people from those countries to HIV, because they have high-risk behavior as well. This is something that's not unique to Fiji. What is unique to Fiji is that we have this drug problem here, and we don't have programs around needle and syringe programs, so that anyone that's visiting the country may not have access to clean needles and syringes, which means they are at risk of HIV while they're here and they're engaging in drug use. So this is something that we need to address, so that we reduce their risk of HIV as well while they're visiting Fiji. And it's something that other Pacific Island countries, they've spoken to us about how they can be part of providing their students and their adults that are coming to Fiji with information and practices that might reduce their risk of HIV while they're visiting Fiji. But those risk reduction practices don't stop when they return home. They need to continue. And this is something that we need to get right across the Pacific.
So if I have to give you a magic wand to change the tide of HIV pandemic we have in this country, what is the first thing you would do if you were given the front seat, which you already do as the HIV task force, to change? What is the first thing you address as one of the first of many steps, I guess, to tackle this issue?
Yeah, definitely we need to focus on our prevention. We need to introduce a needle and syringe program into Fiji. We also need to introduce PrEP into the country. These are what we call, high intervention prevention interventions. But what we need to get better at is identifying combination prevention interventions. It's a combination of various prevention interventions that we give to individuals that are specific to their risks. What we need to identify in Fiji is all the various groups and what risks they have, and making sure they have all the combination prevention interventions they need to reduce their risk of HIV. So that's the prevention side. The other thing that I would like us to do very quickly is to get everyone that's HIV infected on treatment, and that they are successful with their treatment so that their viral load is suppressed, so that they can't transmit HIV to anyone else. So these are the two sides that we need to really get right very quickly. So it's the prevention side and the treatment side, because both work hand in hand.
Amazing. I guess this will be our final message to the amazing viewers who are watching this in-depth discussion between the two of us. What is one action you would want the general public or the people watching the show and anyone in numbers to help the tide, to change the tide of HIV in the country? What is one thing you'd suggest to them?
Become informed. Become informed about risk behavior that you might have. And identify ways in which you can reduce those risks so that you are not exposing yourself to HIV and other bloodborne viruses. I think as individuals, we have a lot of things that we can actually do for ourselves to reduce our risks. But I'm well aware that there are people in our community that, despite all this knowledge and all these skills, may not have the ability to actually reduce those risks. And that's where we as a community as a whole need to address these systematic issues that we all face. And I think a common one we all talk about is gender-based violence, because a lot of that drives a lot of infections and a lot of high-risk behavior. And a lot of people that just don't have the ability to negotiate the interventions that they need to reduce their risk of any type of infection, including unplanned pregnancy. So this is something that those of us in programs like the SRH and HIV program in the ministry, we're not able to address, because this is a whole of society effort. And I think there are lots of interventions that can be done, but it's really beyond our ministry, and that we need to work right across the board with other ministries, communities, to help reduce the individual's risk of HIV and other risks of infections.
Now, majority people are working. So where does the employment or the private sector, where industries, businesses step in and play a role, from OHS to having sex education in workplaces, and what kind of support structure should they create in this space?
So the private sector has been actively engaging with the Taskforce, trying to identify ways in which they can be, first of all, involved in HIV programming. They are integral to the testing of people who are interested in getting tested for HIV. They are also wanting to provide treatment for HIV. Currently, all treatment is done by the Ministry of Health. There are plans for us to scale up testing and treatment by the private sector, which means if you're somebody who wants to be seen by your private GP, they should be able to do that in due course. It's not going to happen overnight, but there's a plan for that to happen. The private sector or any employer has a responsibility to ensure that there's HIV in the workplace, and there are programs that are being led by organizations like International Labour Organizations or the Ministry of Health that come around to do this workplace HIV. There's information sessions on what you can and cannot do according to the HIV Act, for example. There's also responsibilities as employers. You can't terminate somebody because they're HIV, for example. This is something that we've had in place since we've had the HIV Act in 2011, since the promulgation of that particular decree back then. So this is something that we have very good legislation around for us in Fiji. So I think it's the same with the NGO sector as well. They provide a very important role for the HIV programming.
I guess the whole conversation over here would be the work of responsibility amongst individuals who plays. And let's look at parents, for example, who we often look up to when we take guidance. What role does parents play as a family to addressing this kind of situation? Like, I know one could be families needs to be aware themselves what the problems are in society, such as use of drugs and diseases and whatnot. And I know the often I think a lot of viewers would agree is that they'll tell us to practice abstinence from sex, abstinence from anything else. But we all know that doesn't work. We have tried this for generations and it didn't. What how should the mindset of parents be now?
I always feel we put a lot of responsibility on parents. Talking about sex, even those of us who work in sex, can be very difficult. You know, every time a client walks into your clinic, sometimes you have to work up to be able to speak about sex. And then we're suddenly lumping on parents the responsibility to talk about these very complex issues, which they don't have the skill sets to be able to do. Certainly in the home, we would ideally like our homes to be spaces where children feel safe, children feel like they can talk to their parents about anything. But this is a very difficult ask for many of our communities here because of the taboos around certain topics like sex, for example. But we would like to suggest that parents reach out to the authorities. Anyone that's working with children or adolescents or young people will be a good resource for parents to refer their children to be able to provide that resource, information, behavior change, skills building for their own children around areas that they feel they are not able to comfortably talk about. Ideally, though, like our parents teach us everything, how to feed ourselves, how to dress ourselves. They talk to us about the birds and the bees and sex and all of that. But it can be quite difficult for parents. And I think if parents feel very difficult about it, is to really reach out to anyone that works in this area of sexual health to help them address some of the issues that they can't actually talk about themselves. Mind you, many healthcare workers find it very difficult to talk about sex themselves. And talking about sex is one thing. It can be very, you know, it's very science-based oftentimes, and it's very difficult to have those difficult conversations around sexual practices or things like arousal or things like orgasms and sexual difficulties. All that sort of stuff becomes very difficult for parents to talk about. So I think it's only fair to suggest that parents refer or guide their children towards somebody who might be able to speak about it with them, and provide them as much resource and information as possible. But I think a good starting point for any parents and any family is that the family is welcoming of children asking questions, and that parents find a way, if they find it difficult, to show them where they can get the right information. We are so exposed to information now with with the internet now. And oftentimes the internet becomes a very dangerous place to find information because oftentimes people are learning from the wrong places. So parents could identify a resource that they know is correct, and they can often use that as a way to help children become aware of things that they should be aware of.
So the only way HIV people living with HIV can access this prophylaxis is through the STI hubs, and it's like centralized to one location. And often people feel stigmatized or scared for their identity to be leaked, or even like the general fear of going to such places to get it. They want to seek help, but they often refrain from it. Is there a way ministry or the task force is looking into how we can make this prophylaxis available to private GP clinics, especially those under the PPP program, selective pharmacies, or additional hubs and distribution centers where they can access without being stigmatized, or where their identity can be revealed, which can create further issues in their personal space?
So, as I was saying before, one of the things that HIV is quite different from other disease areas is our involvement of communities. And it's something we want to be doing more of in the HIV response. So whenever we were preparing for the introduction of pre-exposure prophylaxis, we do what we call is a feasibility study. And that was organized by UNAIDS. And what we did was we talked to communities of people we might be giving PrEP to. And we talked to them, like, if you had to pay for it, how much would you be willing to pay? If you were going to go to a place to pick it up, where would you prefer to go? Which doctors do you prefer? Which health facilities? So we have all that information. And And the communities have told us where they prefer to go to. So we have that information. So our programs are going to be designed about putting PrEP and making it available to where communities are asking for us to put it. That's how this is different. So we don't approach it like it's going to be only in health centers, for example, or only in the hub centers. For us, it's just a convenient place for us because the hubs exist and the people in there are well trained, especially in this area. And that's always a good starting point. And then we roll out into various areas because you always want to start off, tweak things to make it better, and then move to the next step. So that's how we will be doing a lot of these interventions. Like for years, treatment has only been in the hub centers, but we've started to roll it out to an NGO that provides treatment and care. So they're doing it well. So we want to move to another NGO, hopefully. And then, we just keep expanding it. So that's how we will approach PrEP, for example. That's how we will be doing it.
Now, often rolling out such large-scale programs, especially nationwide, has its challenges. What is some of the biggest challenges and hurdles has the task force faced, either in terms of working with the public sectors or political leaders or religious leaders who could be blockades or barriers who stood in the way of progress?
Yeah. I think I'll talk about needle and syringe programs because that's the interventions that we initially had some resistance. And I say resistance only because that's what the communities, what we could see from the media. People were sort of talking about that we should just get rid of all drug users or put them all in jail, for example. There's a lot of resistance to any needle and syringe programming. That has become quite silent from what we can see. And our government, our Minister of Health and our Prime Minister are very supportive of the needle and syringe program. So that's a big win for us. Fiji has gone from, in a matter of months, from a bit of resistance towards needle and syringe program to an all-out support in terms of our government. This is amazing stuff because in most countries, it has taken them years for their government to agree to needle and syringe programs. We've only been doing it a couple of months and the government has already said yes to needle and syringe programs. This is amazing. And this is something we should be congratulating the Fiji government on because, as I said, many countries resisted needle and syringe programs for years. I'm not talking months, years. And Fiji is already there. We have a HIV law that says we can have needle and syringe programs. And we have a government that has two strategies, the narcotic strategy, which has needle and syringe programming in it, that has been endorsed by cabinet. And then you have the surge strategy, which has needle and syringes in there. All the policy around needle and syringe programming exists in Fiji. So all we need to do now is implement a program. And this has been where our biggest challenge will be because drug users are new to Fiji in terms of intravenous drug users and our understanding of them from the health side. Like, it's one thing to know anecdotally from what we read in the papers and all of that, but as public health people, we need strong evidence. That's the thing that we don't have here. We don't have strong evidence about the risks that our drug users are engaged with. Those risks are important for us to know so that we can design a program that is appropriate to their needs. And we have learned in recent months that it's not simply about putting needles and syringes into the hands of drug users. It's about the right needles and syringes as well. We don't know that information. We don't know what the appropriate needle and syringes are required for our drug users here because there's been no studies. So it's not a simple case of just putting needles and syringes into their hands. Our drug users are young drug users, young in the sense that we haven't been injecting for 20, 30 years. It's a new risk behavior, which means we have to think about the quality of veins and all that sort of stuff, which is factored into our decision on the type of needle and syringes we need to introduce here. So these are the things that we are not prepared for because we don't have the evidence. So even though we might have the law that supports us, the government that supports us, there is a need for us to get more information about what's happening with our drug users. But because it's such an impact on our health in the country, we cannot wait. So we will be introducing 2 forms of needle and syringes into the country, and then we will do an evaluation of which one's appropriate for our population, and then we will remove the one that's not appropriate. So, this is kind of like some of the realities about introducing a needle and syringe program. No health intervention is ever introduced without any hiccups. We can expect for things to go wrong. The most important thing for us is to make sure we make the right decision based on the information we have. And that's what we're doing in the task force. Is whatever information we have, we work with that until we get newer, stronger evidence, and then we change our programming around it. And we ask that the communities are mindful of our limitations and that we will have to always ask for forgiveness and then introduce new programming that is better for our community. Because we really don't know much here of what's needed in Fiji. And so we just keep changing until we get it right.
Mhm. One of the challenges also, I guess, faced right on the ground level with the health frontline workers, such as the health doctors, who has difficulty accessing information on HIV patients, such as even testing. The turnaround time from the laboratory we should be within 48 to 24 hours, but sometimes due to backlog or unavailability of dyes or kits or whatnot, it always delays the process of treatment. And we had a situation where a young mother and a baby passed away just because they refused to identify themselves as HIV patients. But the medical people, they could not access their health records because, again, the decree and other protection policies protect them. Um, this has become a barrier, and it will become a continuous barrier for these healthcare workers. How can the task force address these challenges?
I can't speak about that particular case because I don't know anything about it. The one thing I can say, every HIV person, any person living with HIV, the circumstances in which they have HIV is unique and complex and not as straightforward as we like to make it sound. We think this happens, so then this should happen. This is never the case with human beings, and that's what we're experiencing in HIV. Because of the level of stigma and discrimination that we face right across the country, we can understand when people are resistant to letting people know, health workers included, that they have actually got HIV. And oftentimes, which is more common than not, most people don't actually know they have HIV. We have a situation in Fiji where the majority of people who are HIV infected, who have been tested for HIV, actually don't know their results. So for the 1,500 cases that were diagnosed with HIV last year, half of them don't know they have HIV because they have not come back for their results. So again, I'm sharing this because it's complex. It's difficult for us to understand why individual cases are not willing to share their status around their HIV status. I can understand why people would be fearful of this because it changes their engagement with healthcare workers a lot of the times when healthcare workers know their status. And I think they're fearful of this. So I can understand why people would not want to share their status. Also, there's also this fear that oftentimes information might slip out and other people in the hospital might be aware of somebody's status. It's happened in the past, and Fiji is a small country, people find out about it. So I can understand people's fear around not wanting to disclose status. Healthcare workers who work in HIV, I'm one of them that used to do this in the past. We protect our patients. We want to make sure that no other person can hurt them because by the time they've arrived at our clinic, they have faced so much stigma and discrimination that it's taken so much for them to walk into our clinic. And so for us to refer them to somewhere else, another health worker, we think about it very hard before we do that. And it may not be because of that health worker. It may be because of other people in the clinic at the time. Sometimes information gets out. And then the person that we are referring to someone else is impacted because we've shared information. Information we have to share because we want another healthcare worker to help them. So what we try to encourage amongst healthcare workers is this idea of shared confidentiality. Between you and I as healthcare workers, it might be fine. But supposing you write somebody's information on a folder, and that folder is read by a general public person that walks in the ward and opens the folder, suddenly other people who are not healthcare workers are aware of somebody else's status. And supposing they know that person and they start spreading the information, this is the kind of situation we're dealing with. I'll remind people, we're not in the city I used to live in, Yangon, which is 6 million people. We are in small settings where oftentimes healthcare workers are related to you. So information gets out, and oftentimes it's often to the detriment of somebody who is HIV positive. So there's a lot of things that we need to think about. I completely understand where you're coming from in terms of how it impacts people's health. But that's where we from the health side, from the Ministry of Health, and for those of us who work in health, need to make sure that our services have this concept of shared confidentiality and the importance of it, and the importance of privacy, and the importance of addressing stigma and discrimination from health services. It's very difficult because our healthcare workers change very often. We have a lot of doctors that come in and out, nurses that come in and out, and oftentimes we train this group of healthcare workers, and then another lot comes in, and we don't provide the training to the new lot fast enough. So, it's a constant thing that we need to do, and we need to get better at it. So, I think it's just an opportunity for us to get better at what we do. So that's our challenge from the Taskforce side.
For the general public, at a time of lot of information, in a time of a lot of information thanks to the internet, there's also not right information. Where does the public need to reach out to get the right information, especially when it comes to treatment and even getting themselves tested? Of course, we have the health sectors, but how do they know that trying to get the report and the results and even the medication? Some, again, we already discussed on the herbal medication. Some might say, oh, you got HIV, great, have these leaves, and rather than have the medication actually given by doctors. What are the platforms you would recommend and you Ministry of Health would advocate on to use to understand the health status of the individual?
Anything to do with health in Fiji, your first point of contact would be the Ministry of Health website, or any resources the Ministry of Health has had a responsibility to develop, because it'll most likely be correct information, and that's a good starting point. The World Health Organization, as you know, is globally renowned for sharing of correct information. That's the second place you can go to. Websites that WHO runs are reliable. All the NGOs that provide SRH, or sexual and reproductive health services, also has information. A lot of that information is Ministry of Health information. So there's other place you can get information from. The other thing would be to look at other ministries of health in other countries who produce information that might be useful for those of us from Fiji. So, like the Australia, New Zealand, the US, the UK, all English-speaking countries. They will have the right information that you would need to be informed of the right information. But I think the important starting point is always the Ministry of Health in Fiji, because it's information that is relevant for those of us who live in Fiji. Oftentimes, some things that Australia might recommend may not be available here, or may not be appropriate for Fiji. So it's always important to start with our own Ministry of Health information, and also all the hub centers here should be able to provide you with information as well.
Thank you so much for this in-depth information. From yourself as the HIV Task Force, if someone is watching this show, where can they seek help? Where are the locations the HIV teams are at, and what are some of the medication and stuff, support network they can access? Is there any advice and information for the Ministry of Health to the general public today?
For anything to do with sexual and reproductive health and HIV, your first point of contact would be any of the hub centers or the SRH clinics. There's one in Lautoka, one in Labasa, and one in Suva. You can just look on the Ministry of Health website, and they should be able to show you exactly where they are located. There are phone numbers on there, so you'll be able to contact them. But because of the national interest around this, there'll be lots of community outreach, and there'll be lots of awareness programs. So that's a good starting point. So if you have access to any of this outreach, this is an opportunity for you to approach somebody to get more information.
Perfect. I guess that kind of wraps up our episode on this. We have more great speakers coming up on the HIV information. Dr. Jason Mitchell, thank you so much for your insight, and thank you on behalf of coming on Ministry of Health on the Debrief Show. Till next time, we will see you again. Thank you.